afternoon. So today we'll start the small cell lung cancer session, and my topic is on discussion of combination of the newer drug Lubinectedin with Doxorubicin for this physician's choice of chemotherapy in patients with relapsed small cell lung cancer. This was the ATLANTIS phase 3 study. So management of small cell lung cancer, as you know, it's a very poor disease with very poor prognosis, and in spite of having good response rates, but the responses are not long lasting, and the overall survival, medium progression-free survival are very poor compared to the other diseases. And this diagram shows that the commonly used regimen of carboplatin, platins and etoposide compared to the CAB regimen used earlier, and nowadays we have moved towards platinum with etoposide. After that, there was a subsequent new development of addition of immunotherapy in the frontline setting based on data of addition of atezolizumab or durvalumab. And here the relapse, even after this, the overall survival is around 12 to 14 months and PFS is around 5 to 6 months. And the relapse usually occurs within the first year, and 40 to 50% of patients will receive subsequent therapy. So clearly there is an unmet need of improvement of outcomes in small cell lung cancers in the first line as well as in the second line. So if we discuss the second line treatment used earlier, the topotecan was the only second line treatment approved, and this was based on the response rate of around 24-25% and median OS of 6 to 8 months in the second line. So current HCN recommendations for second line treatment is Lubinectedin, the newer molecule. So this was discovered from a compound isolated from the sea, from the marine vegetations, that is from the So the rationale of use of Lubinectedin in small cell lung cancer is based on the biology of the disease. Small cell lung cancer is a transcription addicted disease with high levels of dysregulated transcription factors that contribute to tumor initiation and progression. So Lubinectedin acts at multiple levels. Basically, it acts at the transcriptome level, leading to dysregulation of the transcription and further disruption in the cell replication. So there are two trials which were done earlier prior to the ATLANTIS trial. This was the phase 2 basket trial of use of Lubinectedin at 3.2 milligram per meter square. In patients who had received previous platinum, 105 patients were there, and response rate was 35%, with a duration of response of 5 months and OS of 9.3 months. And this was the response rate. And another study which was done prior to the monotherapy study, this was a phase 1 study in which 27 patients of relapsed small cell lung cancer were taken, and here the dose was used was 4 milligram flat dose. Response rate was 65% and duration of response was 6.7 months. So again, a phase 1 expansion cohort study was done to lower down the dose of Lubinectedin because of the adverse events seen earlier, and the response rate was 36%. So based on this, ATLANTIS trial was designed, and this was a phase 3 trial randomizing patients with small cell lung cancer progressed on platinums with a minimum treatment-free interval between the first and second line therapy of more than 1 month, randomizing into combination of Lubinectedin with Doxorubicin versus treatment choice depending on topotecan or CAB regimen. And then after completion of 10 cycles of combination therapy, the patient was put on Lubinectedin if they had maintained response. The primary endpoint of overall survival, and the sample size was calculated on the basis of estimation that the median OS would be 7.5 months compared to the control arm, and these were the baseline characteristics of the patients. So total 613 patients were randomly assigned to Lubinectedin versus the physician's choice, and out of that, 127 received topotecan and 117 received the CAB regimen. So if you see the survival analysis, the median overall survival was 8.6 months in the combination arm versus 7.6 months in the chemotherapy arm, the conventional chemotherapy. The 2-year OS rate was 9% versus 10%. Again, didn't show any statistical or any numerical difference in terms of overall survival. The progression-free survival was again similar in both the arms. It failed to meet OS and PFS endpoints. So these are the Kaplan-Meier curves showing the same that the combination of Lubinectedin with Doxorubicin didn't meet any of the OS or PFS endpoints. So, though the subgroup analysis is not allowed, but if we see, try to analyze in depth, so median PFS and OS were numerically slightly higher in patients having age more than 65 years with lower LDH, kind of a better prognostic disease with a chemotherapy-free interval of more than 6 months and without CNS mets. If we see the adverse events, the Lubinectedin and Doxorubicin had shown lesser adverse events compared to topotecan or CAV regimen. Namely, these adverse events were lesser proportion of patients having anemia or neutropenia or febrile neutropenia. Treatment discontinuation rate because of adverse event was lower in the Lubinectedin and Doxorubicin arm compared to the topotecan CAV. Here it was 13% versus 21%. So this trial failed to show OS improvement, failed to show PFS improvement. However, PFS was better in patients having chemotherapy-free interval of more than 6 months. It was 8.2 months in this versus 4.5 months in the topotecan CAV regimen. Previous phase 3 trial, the topotecan, which established that topotecan is a standard of care in second line, had shown a PFS of 4.3 months in the platinum sensitive, but here the definition was taken as around chemotherapy-free interval of 3 months. Here numerically longer PFS was achieved in patients who had received prior immunotherapy agents. However, such number was very less, so as to have disallow any sort of further assumptions and conclusions. Better safety profile clearly, and lesser treatment discontinuation rate because of the treatment compared to the control group. Also, another thing to note here is because the trial was because here the dose was of Lubinectedin was used as 2 mg per meter square with doxorubicin, and this was 35% lower dose than that used in the monotherapy in the phase 2 basket trial. So, a couple of points to ponder, and there are further trials studying use of this molecule in combination with irinotecan, and also there are some trials going on with combination of use of this molecule with immunotherapy. So, till that time, we have the results. I think second line only monotherapy use is approved, or else option of topotecan.